afternoon, everyone. Thank you very much, Dr. Ayman. And so, let me see if this is. Okay, so probably pointer, does it work? Yeah, let me see if. Yeah, so, yeah, sure. Thank you very much. Okay, so I'll give, like when I was asked to give this talk, I just thought that I'll give a talk on an update of newborn screening, but I'm not sure how much of you are involved in newborn screening. So I just tried to make it a mix between the traditional newborn screening that we do, as well as an update, and I'll proceed with this as time allows. So basically, before starting, let's just talk about newborn screening and get the definitions. So newborn screening, as the name implies, is a public health service that targets rare diseases. And again, in this setting, we put rare between parentheses because the definition of rare is really different. So for me, in my lab, the most frequent disorder that we see is G6PD, and it's probably 1 in 10. So that is not rare at all, right? And some of the disorders that we see is probably 1 in 200,000 or 300,000, or sometimes I have never seen some of the disorders that I have been chasing for many years now. Now, this involves, newborn screening involves checking every baby. To be efficient, it has to check every baby and identify those few ones who look healthy at birth, okay? But they are at risk of one of the several serious disorders, and they can benefit from early detection. Now, we do this through using blood spots. It's a very simple sample to collect and transport and test. And then we look for certain markers, and we look for those disorders that we aim at. Now, the main focus of newborn screening is, of course, to reduce the morbidity and mortality of that particular individual, the baby that we are testing. We are not doing, studies or so. It's just really focused on the baby that we are testing. And it has been described as one of the most successful programs, preventative health programs, in the past years. And it truly can change the life of the individual if picked early and treated early. Now, historically, the whole story started in the 60s when the dry blood spot was invented. Dr. Robert Guthrie, who developed the PKU test, invented the dry blood spot, and that facilitated the ease of, or the possibility of doing a newborn screening. And now, after 2010, we are adding more disorders to the menu. And the most interesting breakthrough happened in the 90s when mass spectrometry, a technology that was developing at that time, was introduced. And lucky enough, that technology, or the use of that technology in newborn screening, started actually in our region at King Faisal Hospital in Saudi Arabia. And the pioneer was Dr. Rashid, who was my mentor during my postdoctoral studies. And here he is with Dr. David Millington, who was also a very influential person in developing newborn screening as we know it now. So both of them really deserve the credit for being the fathers of newborn screening as we know it. And we should all be very proud that Dr. Rashid was at that time at King Faisal Hospital in Riyadh. Sure. So in 2005, few years after Dr. Rashid developed the newborn screening in its current form for amino acids and acyl carnitines, the American College of Medical Genetics organized a very efficient effort toward unifying or making a uniform or introducing a uniform newborn screening menu. They call it the Uniform Screening Panel. And in that panel, about 29 diseases were chosen based on 3 pillars. we understand what the condition is, there is a treatment. So for a condition where there is no treatment, there is no need to screen for, right? So there must be a treatment, there must be a test. And the most disorders that fit in this category are shown here. A few amino acid disorders like PKU, MSUD, tyrosinemia, etc. Some fatty acid oxidation diseases, some organic acidurias, and many of them are common in our region, as well as other disorders such as sickle cell, and some endocrine disorders like hypothyroidism and congenital adrenal hyperplasia. So this was what was introduced for a uniform panel in 2005. Now, after many years, maybe 16, 17 years now, how well are we doing with these disorders? Now, for some of those 29 disorders in that table that I just showed, some of them, the outcome is really great. And one good example is PKU, phenylketonuria. Now, if we don't pick a PKU child early on, and we don't treat them, they truly develop profound intellectual disability, and they will never be, able to be independent, go to school, go to university, and they have very low IQ. However, PKU patients picked at the newborn period and treated appropriately can develop completely normally. I've seen some of them, studying languages, learning, in medical schools, and they are just, well-treated PKUs. Now, for this group, there are many others, such as congenital hypothyroidism. You probably agree with me. If we pick them early, we give them thyroxine, they are treated, they will do well. Now, and there are many others, of course, in this group, such as, the vitamin B6 responsive homocystinuria, vitamin B12 responsive methylmalonic aciduria. Now, some of them, it's in the middle, like galactosemia. Galactosemia, if we don't pick them, they will probably die because of sepsis or develop, again, profound intellectual disability, and the outcome is worse. However, if we pick GALT, they might not die early. However, they will not be completely functional in their future. And in this group, there's also another disorders such as the urea cycle disorders, citrullinemia, sickle cell as well, CF belong probably to this group. Now, there are disorders that we are uncertain at all of what we are doing with. We pick them, we try to do our best. However, they keep coming back to hospitals. And one good example is propionic acidemia, where there's recurrent admissions even after we pick them. And another example is also the methylmalonic acidemia, 3-methylproteinyl-CoA carboxylase that the previous speaker mentioned in one of the families they studied. Well, so this is really about the previous or the original menu of a newborn screening. Now, because we have already learned a lot about a newborn screening, then there was a need to start adding, more conditions. And the most robust system was developed in the United States for adding new disorders to the newborn screening panel. And there is a committee that studies this and then does recommend adding or removing disorders from the panel. It all starts with any person, even one of you in the audience, go forward and nominate a condition. So let's screen for condition A. Then the committee studies that condition, and if they vote that yes, there is good evidence that we should be doing this, then they will kind of recruit an external panel to study that and create evidence-based conclusion whether to add this condition, and then they go through this process of voting and studying and then going back and forth until the condition can be accepted or rejected for screening. Now, many of the conditions that I just put in this list have been nominated in a way or another for screening. Now, this was because of the introduction of a new screening technology. So there's a test. Some of them because of a new treatment. Okay, now Duchenne, XALD, Fragile X, etc., all of those were evaluated and studied. Now, SCID was the severe combined immune deficiency, which is an immunological disorder that can lead to death if not picked and treated early. Was approved for newborn screening in 2010, so almost 10 years or 12 years now. Other disorders, congenital heart diseases, Pompe disease, Hurler disease, MPS1, and XALD, and most recently, spinal muscular atrophy was added to the newborn screening panel. So if you look at, or if you remember the title of the talk, so if we are talking about an update, so this is the update. Whatever was in the previous table is the history of newborn screening. The additional conditions are the update, which I will dedicate the coming minutes for. So this is now the newborn screening panel in 2018 with about 35 disorders, and we have SCID, Pompe, MPS1, XALD, spinal muscular atrophy. I skipped the congenital heart disease because it's not detected, of course, on dry blood spot. I'm focusing on the conditions that we do on the dry blood spot. Well, SCID, severe combined immune deficiency. So immunologists among us probably are familiar with this picture, the child with thrush. So this disorder is caused by severe immunodeficiency, and patients usually present with this, once the antibodies from mother have declined, so 4 or 5 months of age, and then they start to show some infections, chronic diarrhea, pneumonia, and failure to thrive, as well as the oral stress that I'm showing in the picture. Now, the marker, the screening marker, is measuring the TREX, the T cell receptor excision circles in the dry blood spot. So it's a real-time PCR test. And the treatment for this is of course, bone marrow transplant, and it is very useful and very successful. Now, there are other treatments such as gene therapy and enzyme replacement that have also been in use for certain types of SCID. Now, the testing for SCID shows, as I said, a marker, which is the TREC, which is shown here to be very low as compared with the normal population, and all the testing is done on blood spot. And after a few years of screening in the US, there was a big publication summarizing the outcome of 11 screening programs. More than 3 million babies were tested in this period. Now, the incidence rate of the disorder was 1 in about 58,000. And please remember this number, because I'm coming to it in the next slide to compare with our region. Now, the survival rate was more than 90% when these patients were treated appropriately. So the patient is detected with low TREX. We know that we confirm that they have SCID. Then we prepare them for a transplantation. If that is done within the first 3 months of life, most likely they will live. Sure. Now, all the American states, all of them are testing for SCID, and this gives you that when this like a hint on this was introduced first, then with one state, then 2 states, now everyone is screening for this. Now, in comparison with our region, this study was from Kuwait. It shows that the estimated incidence of SCID is 1 in about 7,000. So compare it in 1 in 60,000 that was published in the large study in the US. So this tells you that in our region, we are probably 10-fold higher than or approximately 10-fold higher than North America. Now, if we go to this study from Saudi Arabia, the outcome was even more, showing that the incidence rate of SCID is 1 in 2,900. And this is truly high. Now, if we think about this, this is much more frequent than many of the other diseases that we screen for, right? So PKU, probably it's 1 in 10,000, 15,000. All of us screen for that. But now, if you look at this condition, it really fulfills the screening criteria very well, from treatment, from incidence rate, etc. Well, I hope that the argument was good, that you agree that SCID is something to add. let me now move to Pompe disease, glycogen storage disease type 2. This disease was described in the 30s. It's an autosomal recessive disorder, about 1 in 40,000, and it's caused by an enzyme deficiency in alpha glucosidase. Like many other disorders in the inborn error of metabolism world, there are infantile onset and late onset, severe, less severe, and this disease can be treated by enzyme replacement therapy and very well. And yesterday there was a talk about enzyme replacement therapy, and Pompe came in the discussion. It was recommended in 2015, so about 7 years now, and there are good screening methods and good confirmatory methods for this disorder. Now, when Pompe was introduced first, only 4 states screened for it. Now, after those 6 years, you can see that a larger number of states is screening for Pompe, so more and more babies are benefiting from this screening program. This study came from Pennsylvania, and I just want to show you here in this table that the frequency of late onset as well as infantile onset Pompe disease is about 1 in 16,000. So again, this is from Pennsylvania. So I'm sure that if we do this type of study in our region, we'll find a higher frequency due to the cultural factors that contribute to, the high rate of autosomal recessive disorders in our region. Now, let me move to the third disorder that was added to the panel, and that was MPS I, or Hurler disease, Hurler-Scheie disease as well. So this disorder is an autosomal recessive lysosomal storage disease caused by L-iduronidase deficiency. It's a multi-organ disorder, and it has variable severity, and it's a progressive disorder. So when they are born, you cannot tell that this is a Hurler or so. And again, there's the severe, which is known as Hurler, which has developmental delay, skeletal dysplasia, hearing loss, coarse facies, etc., etc., and they usually die before the age of 10. And there is the attenuated form. Some of them do much better with no developmental delay, and the disorder can be treated with enzyme replacement therapy as well as stem cell transplantation. Now, if they are transplanted at the right age, which is less than 2 years of age, they can do very well. However, if damage happens, then it cannot be reversed. So that's why we need to pick them early, treat them, then they will do well. Well, as I said, it was recommended in 2016, and it has good methods, biochemical and molecular, for testing and confirmation. And in 2016, about 4 states were screening for this, and now more than half of the US population is being screened for this. And again, unfortunately, we don't screen for this in our region, but we should learn from others that screening for this is probably quite useful. Now, this is a 5-year study of neonatal screening for Pompe disease in a large number of programs. I'm showing this. Unfortunately, this is not very clear, but what I just wanted to show is that in different countries like Taiwan, Italy, and then a couple of or a number of states in the US, many places are screening for this. And what I wanted to show here is that the incidence rate of this is also quite significant. And in some programs, it was 1 in about 30,000. However, this data is probably not very much reliable because the number of screened babies were not that high. Now, the fourth condition that I'm going to talk about is X-linked adrenal leukodystrophy, which our neurologist colleague this morning spoke about. So this is a peroxisomal disorder, and it's X-linked. So this really complicates the screening process, because we would think that boys are more affected, right, than girls, because boys have 1 X chromosomes, girls have 2. Well, it's the most common peroxisomal disorder. As the name implies, it affects the adrenal cortex as well as the central nervous system. It has a truly broad clinical phenotype, even among the same family. So you could have 2 brothers having XALD. One of them is affected severely and the other is affected minimally. And the condition can be treated with transplantation as well as with certain replacement medications. Now, it was approved in 2016, and the marker of this is a very long chain fatty acid. Unfortunately, this very long chain fatty acid that we test for this condition, which is the C26 lysophosphatidylcholine, also would pick another group of disorders that are the Zellweger spectrum disorder, which is a very severe group of conditions, of peroxisomal conditions that cannot be avoided, So we have to be very careful when we decide to screen for XALD to avoid incidental findings, right? Now, this is just to show the biomarker. So this is the normal newborn population, and this is the abnormal population. And as you can see, there's a good segregation and a good specificity in the testing. Now, this is a study from Illinois, which was published this year, and I'm showing this table. I know it's extensive, but I want you just to notice that many of the affected babies are actually females, right? So we are talking about an X-linked disorder, right? Now, this is another discussion that we can have, but this is, so if you look at the ones now which are remaining on the screen, these are the baby girls. 10 of the affected babies among more than 270,000 screened babies and confirmed are females. Now, that puts a lot of pressure on the families as well as on the lab, because this is some of the females will be manifesting in future. So as you can see, a large number of states are now screening for this. And the last disorder that I would like to finish before my time is over is SMA, spinal muscular atrophy, which was the most recent addition to the screening. So this is actually the cherry on top of the. So it was the last disorder added to the screening panel. And the most interesting part about this is the incidence. So this disorder has a very high incidence. It's 1 in 10,000. And it's treatable. I know the treatment is very expensive and it's cost probably 8 million dirham to treat one child. However, it's a single injection, right? Or one of the treatments is one injection, you inject the baby, they go and they do well, right? So the incidence rate is quite high. It's much higher than many other disorders that we screen for. Okay, and the treatment is basically due to the nature of genetic material that we have for SMN1 and SMN2 genes. So this is the non-functional gene, and this is the functional gene. So we get all our protein from SMN1 gene. And then only 10% of the functional protein comes from SMN2. So if this SMN1 has a mutation, this non-functional gene contributes about 10%, which is not enough. However, the expression of this gene can be augmented by that, molecular medications, gene therapy, and then we can increase this from 10, 20, 30 until it becomes sufficient for survival. And then based on the number of SMN2 gene, we classify SMA type 1, 2, 3, 4. Now, if we have 4 or more, or even 3 or more copies of SMN2, which is the non-functional gene, patients could live normal lifespan. And if we treat them, then we will provide more of the SMN protein, and that will provide them with sufficient protein to survive. Now, the treatments that are available is either the gene transfer, the gene therapy, and this is, I think, the one single injection treatment, and then, or you can give them, those medications that could be the antisense oligonucleotides or the small molecules that alter the splicing of SMN2 and provide the body with sufficient amount of protein. Very interesting treatment approach. However, it's showing that it's really working. So again, although this condition was introduced in 2018. Now, most of the blue ones are the ones that's universally screening for it. As you can see in the United States, most of the states are taking this in consideration. Now, this is the updated panel, and this is the these are the conditions that are being screened for now with the update. And I think more disorders are being recommended now. I have seen on LinkedIn, like, that Hunter disease, MPS II, and GANT, which is a disorder in the creatine synthetic pathway, have already been approved or recommended for screening. So there are more disorders depending on the treatment, as well as the development of screening technology. Thank you very much.